Welcome to our online course called Why NAIOMT. My name is Michael Lucido, and I'm a faculty instructor and examiner in Dallas. And this is a case study that we hope that you find interesting. It's also a case study that kind of shows you or exhibits how we teach our courses. Our courses are pretty much based on clinical reasoning, and this case study outlines the steps in that process. So you can see from the pain diagram that the individual is complaining of left ankle pain, and it's primarily in the anterior region of the ankle as the shank meets the foot. This is a 25-year-old man complaining of left anterior left ankle pain, as referred to outpatient physical therapy. The pain had been present for about 2 weeks. There was no apparent cause, and the onset was gradual, becoming worse over a period of 3 days. He has no history of pain or injury to the ankle, and no history of any lower limb problems. He does state that he had back surgery 6 months ago, but states that his back feels fine. The pain came on during walking, just before a heel lift when he stretched his calf muscles while prior to running. He is an established runner and getting his miles back up after back surgery. He has no medical history to note. He is a graduate student. He likes to run about 4 miles during the week. Other activities include softball and kayaking. He neither smokes or drinks, and this is his second visit to the physical therapist. The first visit was not effective, and he left because he didn't feel like he was making any progress, which is a very common occurrence for therapists who are trained in the NAIOMT system. We typically are the second, sometimes third or fourth physical therapist, because the first basic therapist or basic approach did not work for a patient. Therefore, we're more of a problem-solving type institute and seeing more of the tougher cases. So this is pretty typical for a NAIOMT type therapist to see a patient after they've been through other therapists. So looking at his history just a little bit closer, there's a couple of things that are of interest. One of them is the location of the pain is very interesting, because most people who complain of left anterior ankle pain actually have an ankle problem, or at least a history of an ankle problem somewhere of significance. This individual is complaining of absolutely no history at all of an ankle problem. In fact, he's saying that this was an insidious onset. He's an established runner, and he is slowly building his miles back up after back surgery. So as far as the ankle, and as far as the clinical reasoning process, and we're using inductive and inductive reasoning, we teach both, and most experts in what we do are kind of flowing in and out of deductive reasoning. As far as the reasoning is concerned, this is again interesting as far as the location of symptoms. The other interesting issue is that the pain is fairly localized, and he's not having any other type of complaints. He did have back surgery 6 months ago, and to us, that can be significant. Of course, we're taking information in from the history primarily, and we will hopefully, our examination will hopefully confirm what we're thinking in our history. But the fact that this came on insidiously, he can't really tell us about an incident or a accident that he had regarding his ankle or his foot or his lower leg, and it's an insidious onset, leads us to think in the deductive reasoning process that there could be more to this problem other than just his ankle, and hopefully the examination will provide more clarity as far as the provisional diagnosis. The other issue regarding looking at this patient from a pathoanatomical differential diagnosis is that anytime a person that has an insidious onset of joint pain, and it's notable, sometimes it can be something that's related to an autoimmune issue, such as gout or something like an inflammatory arthritis. The reason why we're probably not thinking that, even though we do consider it, is that it's not symmetrical. Many arthritides, at least from a systemic standpoint, affect both ankles or both hands or both wrists, both knees. This is very isolated to the one side of the body, which is the left side. So we would also be interested to see if there is warmth coming off from palpation, which we'll get to in the objective part of the examination. Mild to moderate warmth without a history of trauma would lead us to think maybe there's something else going on from a systemic standpoint. But none of that in the history is leading to that particular direction, even though we're considering it. So regarding this particular case study, we have some questions here that we would, in our courses, would typically throw out and have people begin to think and discuss. What kind of pain are you dealing with? This individual is describing something, and we typically try to categorize the nature or the opposite or the what type of pain we're actually dealing with, because that helps us lead us to what kind of tissue we're dealing with. Is there paresthesia? Paresthesia is primarily pins and needles, and he is not describing this. He's more describing your classic, more of a somatic type pain, kind of a deep achy type sensation in the front of his ankle. Radicular pain is a pain that's very well studied and very well established. He is not complaining of radicular pain. Radicular pain typically is more lancinating. It's an inch to an inch and a half wide. It's sharp in nature, and it shoots down the upper or the arm or the leg. So he's not describing that. He's describing a very localized issue. So based on the history and what you know about his pain, what would you say right now is your provisional diagnosis? And we call it provisional because many times we're making the best judgment we can on the information that's provided to us. Many times we may change our diagnosis after a visit or two or maybe even three based on more information coming our way, more reasoning, more details coming from examination. So we call this a provisional diagnosis because we may not know the exact answer initially, but we have a really good feel for the recognition pattern, at least based on the first visit. What more information do you need at this particular time? So during your examination, you'd be looking for very specific type of information that would lead you one way or another thinking this is an ankle problem, or perhaps this is being contributed by something else, such as his previous spinal surgery problem. And where would you start your examination? Would you start this examination in a peripheral joint, such as the ankle, lower leg? And again, there's no real wrong answers here. Or would you start this in another type of an examination, starting in the spine? And again, none of these are incorrect. It's all a process of reasoning, and we'll walk through that coming up. So here's a slide as we're thinking about our case study here. This 25-year-old man that had an insidious onset of ankle pain. He's a runner and he had back surgery 6 months ago. And here's two bits of information in the deductive reasoning model. What kind of pain is he actually having? And we're talking about, like I mentioned earlier, is he having a very specific type of pain, what we call neuropathic type pain. Neuropathic type pain is very easily recognizable, easily described by the patient, and he's not having that. Is he having localized pain? He is, but you may consider this is also what's called referred pain. Referred pain is coming typically from the spine or another structure that can refer segmentally. So the brain is picking up this signal coming from a segmental referral. And if you were to look at where he's pointing to where his symptoms are, you would say if this was truly referred pain from a somatic structure and a segmentally derived neurological segment, this is an L4 neurological level that he's pointing to. The pain is in front of his ankle. If you look at the L4 dermatome, it does cross the front of the ankle. And so we would consider this to be an L4, maybe even an L5 type of distribution as far as where his ankle is actually hurting. If we were to take the anatomy of the ankle and palpate through the anatomy, We could say that there was skin, subcutaneous tissue. There would be ligaments covering the front of the ankle. There would be a large tendon, anterior tibialis, and other tendons that are crossing the anterior aspect of the ankle. All those are possible pain generators. If you go a little further than that, you have the capsule complex, and then you have the intra-articular structure such as the hyaline cartilage and the synovial membrane that covers the synovial joint. So all those are possible pain generators, but again, there was no history of a sprain or an overuse injury or a trauma to the ankle. So at this particular phase of the game, we're actually into our deductive reasoning process, and we're considering other possibilities even before we examine the patient. So we were talking about pain localization. Now let's talk about another thing is we're looking for weakness. And weakness and pain together, when you look at both of these together, leads us into further deductive reasoning. What type of we're going to look for weakness in this examination, and the weakness is going to help us decide which way we're going to go. And these are all descriptions of, or descriptors of, what type of weakness the person may actually have. Is it coming from the spinal cord? Is it coming from what we call facilitation? Is it more reflexive or painful type of weakness? Or is it what's called a radicular or a palsy type weakness? This kind of weakness is much more fatigable when we test it clinically. It drops off in strength much faster than the other types of weaknesses that we see coming from ankle joints and from patients who've had trauma to the ankle. So in our model, we have a patient with this history. We've already done some reasoning through it based on what we know from the history. We've considered We've considered the patient's pain drawing, and we're ready to examine the patient. Look at our model. Our model is a very structured examination process that leads to clarity and a reasonable, rational treatment. And we believe this approach to a physical therapy examination is consistent. It provides a great framework for examination and assessment. So with this in mind, our examination is actually going to start at the lumbar spine. And we believe this is the place to actually start the examination because of his history of low back surgery, and there's been no history of trauma to the ankle. There appears to be a skin sensitivity around the ankle itself, representing the L4 dermatome. And we know that running can be a tough exercise, especially after someone who's had back surgery. And a 25-year-old, he had a discectomy, so that tells us that part of the annulus has been removed, and that might be part of the problem with him running again. So through that reasoning process, we're going to start with the lumbar spine, and we do what's called the lumbar scan. It's a fairly efficient look at the most significant parts of the lower quadrant. And we're starting with basic range of motion of the lumbar spine. We're going to do a neurological examination, including reflex sensation, motor testing. We then go through palpation for sensation around the ankle as well as the lumbar spine. And we notice that with this particular case study, here's our objective findings. They have skin hypersensitivity around the top of the ankle. There's no swelling or warmth around the ankle that would suggest an effusion or a joint related problem. He has full range of motion of the ankle as well as his knee, and he has weakness to the ankle everters, which is interesting because weakness represents a neurological issue at times. And if you look at the everters, the fibularis longus and brevis, this is an L5, S1, and L4 contribution to this muscle group. And since he had back surgery, this may be contributing to the weakness of his everters. There were no other muscle groups that were weak when we tested his ankle. So this is the only finding we had as far as a neurological finding. And in our courses, when we teach this, we ask ourselves, what other muscle group would represent the same neurological level as the L3, L4 everters? Sorry, the ankle everters. Well, the ankle everters are primarily innervated by L5S1, coming from the deep peroneal nerve innervation, typically an L5S1 innervation. We might want to know what level of back surgery we actually had. If we had an L45, L5S1 microdiscectomy, this might be consistent with weakness showing up as an L5-S1 neurological level. So we might want to then go back and find out what level he had surgery at. And in this particular case study, he did actually have an L4-5 microdiscectomy 6 months ago. He did not do any rehabilitation after his back surgery. His neurosurgeon said, walk for 2 to 3 months and then you can go back to running, which is exactly what he did. So in our examination, we would then ask ourselves, what other muscle group could we test that's not in the ankle itself to confirm the fact this is a neurologically weak muscle group, which we would then move to the gluteus medius. The gluteus medius obviously is not an ankle muscle, but it is innervated by the same neurological level as the everters of the ankle. So by testing the gluteus medius, we get integrity of the L5 neurological level. And indeed, in this particular case, the person was extremely weak on the left when we tested his gluteus medius hip abductors. So there were no other muscle groups that were weak in the lower quadrant other than his everters and his gluteus medius, which made us think this was coming from the L5 nerve root, which would be consistent from the L4, L5 microdiscectomy, which pretty much leads us to the fact this is actually a lumbar issue causing his ankle weakness, and that's exactly how we went about treating the patient. You can see an outline based on what we actually did over a series of 3 to 4 weeks regarding this particular individual. So our treatment, again, we're looking for a rational treatment based on our clinical pattern recognition, inductive and deductive reasoning. And this ends up being a very reasonable treatment. We started performing what's called neural glides on the first day of treatment. Also taught the patient how to do it himself. Neural glides has the ability to mobilize intraneural edema as well as mobilize scar tissue that's been built up around the nerve root. And this is the important exercise he actually did at home as well. We also did some soft tissue work around the ankle, noticing that he had some what appeared to be edematous type soft tissue around the ankle, such as the anterior tibialis and peroneus longus and brevis. Within over 4 weeks or so, we taught him proprioceptive and balance exercises, as well as some neuromuscular reeducation exercises at the ankle and of the lumbar pelvic region, since he did not have any after surgery. And here's a nice slide of what the neural tissue looks like under tension versus in a slackened or relaxed type position. And just notice that scar or neurological tissue is very dynamic. It has to be able to move and slide and glide through all the neuroforamen, throughout the intricacies of the spinal canal. And spinal scarring is very, very common after surgery, after herniated disc that are treated conservatively as well as postoperatively. And this could be the reason why the patient is actually having this particular problem. Neural scarring leads to a sensitivity of the nerve, and this could be over the L4 nerve root or the L4 neurological level, could be explaining why he was having sensitivity around the front of the ankle. So here's a quick summary of what we ended up having a very good outcome with this individual. Again, this was the second time he had been to a physical therapist. He even said himself this looked very different than the first one. And as a NAIOMT type of institute, we take pride in that. So we had 7 treatments over 4 weeks, which is very, very good efficiency. His lower extremity functional scale improved over 85% over that particular 4-week time, and he was running again approximately 8 weeks after physical therapy was discharged, after he was able to build up his neuromuscular control of his lumbar spine, his pelvis, and his hip, as well as his neural gliding exercises, which all improved his strength and function. And he was able to return to running about 8 weeks after being discharged. And we're very, very happy for him. He had a great outcome, and it was our NAIOMT clinical reasoning and our education through our institute that helped us get this patient to perform better. And ultimately, the outcome is really what we're looking for, not a credential or a certification process, but ultimately this individual returning to running is really the outcome we're looking for. and improve function. So we believe that this represents a very solid way of or looking at our institute. It is an institute that makes physical therapists think. And here is about 3 references that we are providing for this particular case.